So this is my homeland. Just a reminder to me, we're changing gears. So, just some ideas, some just general ideas around relationship building and communication. Remember, I present very often to non-Aboriginal health science students, and they say, well, give us something practical, not just some ideas, but, what can I do that will help me out? And I say, well, first of all, Aboriginal people are going to present differently. They can be extremely withdrawn, or they can be in extreme denial. They can be minimizing their symptoms. They can be avoiding the truth of the situation. They can be angry or fearful because, my gosh, they have such a long history of being treated really poorly. And you should expect that if you're a health worker who is surprised by an Aboriginal person who is mistrustful, then you are terribly naive. And you need to leave that naivete behind. So, patients can come in, they can be angry, they can have a chip on their shoulder, they can be fearful about, gosh, how am I going to be treated this time? And that this is based in a historical context. That I don't know why any of us believe in institutions. I don't know who believed in institutions before and set them up. Sometimes they're not that helpful. And when I'm seen as being part of a hospital staff, it's not as helpful as when I'm seen as an individual who's trying to help. And this last point here, the second point on this slide, the involvement of extended family, community leaders, helpers, and elders in care and decision-making may require special consultation. For those of you who are having difficulty with a particular Aboriginal client, call in the family. It's top of my list of general recommendations. Bring in the family, ask them to help you out. So that's the second point I want you to remember for today. If you're worried about your client and you don't know what to do, bring in their family. So, we need to support them in their anger and in their misunderstanding and in their grief and their frustration. We need to be able to say, I get it, okay? I know. You deserved better than what you received. I know that your current experience of loss and pain is complicated by your past experience of loss and pain, but I'm here to help. So let's work together. And that when people are stressed, they're at their worst. You all know this, that the man who abuses doesn't abuse all the time. He abuses when he's stressed. He's abusive when things are going really, really badly. He's freaking out. And probably a lot of you are like this as well. When things are going really, really tough and you are just stretched to the limit, you're going to snap at any moment. I've certainly been there. And so when we encounter people, they're often at their worst. They're at their absolute worst. They'll never be that bad ever again. And so we just need to be mindful of that ourselves. And that we need to support this stress, try and help them get to what they need to, and help them in their grieving in that moment, because the ecology of health and wellness is that some of us are getting better, some of us are staying the same, and some of us are getting worse. That's just the way it is. Some of our clients are getting worse and they're not going to get better, and some of them are going to die. I know for many of you, you're not dealing with populations who are palliative, and many of you are not dealing with patients who are that extreme, but some of us are. And so in the whole ecology of things, some of our patients are not getting better. So we need to still be able to support them in that grieving and in that pain and in that stress. And we need to be comfortable sitting with them. It's very hard dealing with patients in crisis, for sure. One bit of advice is not to be invested in the outcome. That if we give a little bit of ourselves to everyone who's in trouble, when things don't turn out very well, a little bit of ourselves goes away or dies with them. Instead, we can say, I'm here. You're my 20th patient this year who's dying, but I can still be with you and I can still be compassionate, but I'm not going to lie down and die with you. I'm going to be okay with this. I can deal with this, and we're going to get through it. So, being comfortable sitting with them, being confident, giving them an opportunity to speak to you is the best that you can do. So, the helper needs to have an effective process then for dealing with this. Many of us have suffered terrible vicarious trauma. We've seen horrible stuff in our clientele. And unfortunately, the system doesn't support us. Like, none of you can call in, well, very few of you can call in and say, you know what, I just went through this thing with this client, and I feel really hurt, and I'm not going to come in for a couple of days because I'm going to take care of myself. We're not allowed to do that, which is really unfair, because I know some of you have had your cans kicked by some of the stuff that you've seen. But we still need to have a plan to try and feel better, to get better. So how do we help our patients? Some helpful questions. So these are for kind of the more junior learners. Just ask them, you know, what's the hardest part of what's happening with you? You know, what are you scared of? I don't understand. Can you tell me? How can I make this experience be less fearful? How can I help you with your fear? What's going to help you? And sometimes it's something like, you know what, I need to call my sister. And you say, okay, I can help you with that. Doesn't use any of your medical knowledge, but it's what they've asked for, and so you go there. And then in our communication patterns, you know this, Aboriginal communication is a little bit slower. Most Indians don't talk as quickly or as much as I do. Or you do. They'll often be very careful in their speech as they try and describe to you as honestly and as deeply as possible what they're experiencing. And so there can be long spaces while they think. And that can be really frustrating for some healthcare workers who are trying to keep to that 7.5-minute consult, or who are looking at their watch thinking, God, I have 21 more patients to see in these rounds. So, talking about culture. It is really hard to talk about race and culture. For some of us. And definitely when we're training healthcare workers, it's very hard for them. For many of them, they say something like, oh, you know what, to me, race and culture don't really exist. When I look at you, I don't really see your color or what you are. I see a person, a soul, a light, I don't know. But you have to say, well, you know what, I am a person of color. I am an Aboriginal person. I come from a certain reality, and you should be able to see that my perspective is different from yours. And so we should be able to talk about the fact that we have different ideas from others. And that when we are working, we need to be open to the idea of being chosen. That someone can say, look, we're going to talk about this factually and in depth. Here's what's happening. Here's what it's like. And that's the gift we give to our clients. It's the chance. It's the chance to talk, and we are able to be chosen in that moment. So, cultural norms may mean that they're not very direct in telling us about what's occurring, and that we need to have some local knowledge about how to interact with these people, interact with our clients in the most effective way. And we can ask for help. We can ask those in the know. For instance, I might come to you and say, look, I have a 15-year-old patient. She wants to talk about birth control. She's really embarrassed. I'm really trying to get through to her that, you know, she has many, many options and she should go for it. But she seems nervous around me, or she's not being truthful or something. Can you help me? I should be able to say that to my colleagues. And remember, the idea of working in solitude is a crazy one. We're part of a team. We're part of a team. So I have medical knowledge, but I don't have local knowledge. I'm a man. I'm not a woman. I'm of a certain generation, so I might have trouble with someone older or someone younger. So I need my team members. You know, I have lots of things that I can't do, and there are lots of things that I can do that I'm really happy to share with you. And I would invite you to say, well, if you need medical advice, then come to me. You know, if you need other kinds of advice, like advice about how to work with kids, then don't ask me. I have no idea. So sharing our perspectives. Aboriginal people are, I think by and large, at least in my experience, much more open and trusting when they're connecting with caregivers. And that they're generally more comfortable in sharing about themselves and their lives. They're just a little more transparent. And that their sense of appropriate professional distance is different. Because very often when I'm working in, say, Point Grey in Vancouver, my interaction with non-Aboriginal people is completely transactional. They come in, they say, this is what I want these kinds of medications, thank you very much. In fact, sometimes they don't even say thank you, and they leave. And we've had no connection. I have no idea what their name is or what they like to do. They have no idea who I am. They don't care. I could be the the guy at McDonald's who gives them fries, right? It's not a connection. But with Aboriginal people, they very often they'll want to connect with you on a deeper level, and they'll say, well, why should I be trusting you with this stuff that's in front of us? And so when I'm teaching health science workers or health science students, I tell them, be personable, be a human being. Don't do the posturing stuff. You have lots of time to posture as a healthcare worker. Just be a person. You'll get better results. So family and community conflicts, they're just there. I won't spend much time here because it's not really the point of why I'm here. Residential school. You all know about that. Reflective practice and personal balance was mentioned already, that we need to have healthcare workers that can think about where they're working from. For instance, I remember one nurse describing, I had this patient, this Aboriginal client, he was dying. I really needed to get some vital signs and move on. I had to move quickly. So I was in there, I was trying to go as quickly as I could, and the daughter said, would you please be careful when you're in here? You're really disruptive. And we want our parent to die peacefully without you clanging around. And so she said she understood that. So whenever she was going to go into that room again, she just stopped for a moment and she said, okay, where am I at? I'm okay. I can do this. I will be unobtrusive. And that wasn't much of a preparation, but they asked her to kind of be self-reflective. Where am I at? So self-awareness in the caregiver, some self-analysis is something that we should be asking for. It's kind of a strange concept, and I hope that all of you will kind of reflect on this and think, how do I get my workers to be self-reflective so that they're more efficient and that they're better at what they do? So, reflective practice involves looking at where we're from. We can only work from what we know. We can only work from where we're from. So, if I'm a white-haired, middle-aged physician who's never worked with Aboriginal people, how can I have knowledge of Aboriginal people? So we have to be kind of forgiving and say, well, he knows what he knows and he can grow and change. Or our clients, well, if you're a drug-addicted prostitute, then maybe it's understandable that you're fearful at the moment in interacting with me, someone that you perceive as having power. And that personal balance should be encouraged in our workers. The system is not very healthy. The system asks our workers to go through phenomenal pain, long hours, unsupported. It's a really mean-spirited environment. Gosh, when I hang with I think some of you have probably heard me say this, when I was hanging with Indigenous physicians for a year, we were trying to form a national organization. Those were some of the most disgusting interactions I've ever had with anyone. Indigenous physicians playing physician roles. What's your source? What's your evidence? You have no idea. You went to that university. You work in this system. You don't know anything about that. You know what? I'm full Indian and you're half. Oh, you're from the city. You have no idea what it's like on the right. We were such jerks. And it wasn't until we had our elders come into our meetings that we started to behave honorably and like human beings and not like dogs. And it was so clear to me that here all of these Indigenous people who had gone through medical school and they took on all that ridiculous posturing, that really stupid role, and I don't know why anyone would want to play that kind of role, but they would do that with each other. And so the way around that then is to teach balance, is to say, you know what, the medical schools, they don't know everything. Here are some ideas about wellness from our point of view. Sensitivity, sensibility, in 3 aspects. What's going on for me now? What's going on for them right now? What are we going to do together? Just very simple. So, let's go back to the issues and challenges again. Refocus us. We experience poor health as Aboriginal people. There's a lack of us. Like I said, there should be 10,000 of us, and that's a problem. that our curricula is not culturally appropriate. We're not learning how to deal with Aboriginal peoples in our schools. We have to learn it on the job or from other Aboriginal workers. That we have difficulty retaining healthcare providers in our communities, and there's a long tradition of non-Aboriginal people working in our communities. It's been happening for 6 generations. We've had non-Aboriginal people working with us to help Aboriginal people be better. They are not our enemies. We need to work and partner with them. And that doesn't mean beating them up, and it doesn't mean making them feel like second-class workers. It means an honest partnership, because we're not going to have enough healthcare workers for maybe another 50 years if our numbers are continuing the same. And that community stories, like I said, to a T, down to the person, have horror stories about how they've been treated. So, the medical agenda versus the community agenda. The main reason that healthcare workers fail is that they fail to see the community. They see the individuals, they know how to work with individual clients, sometimes pretty well, but they don't know about the community. And if we're going to work in communities, then we need to know those communities. So those communities have a life unto themselves, some ideas about how their children should be treated, some ideas around how their elders should be treated, ideas around how you say hello that need to be honored. And that we need to move from an academia-centered process to a community-directed process. Why does academia or the medical school or the nursing school know better than us in communities how to deal with our people? They don't, and of course they don't. So why should we expect then those institutions to teach those students how to work with us? We unfortunately have to take it on. And that the medical and the governmental voice in our health is sometimes opposed, diametrically opposed to the patient's voice. It supersedes. It's just one that we hear too often. That's not quite right, because I work for government, but we do need to hear more from clients and from Aboriginal peoples, Aboriginal workers. And that effectively, we have been silenced. Effectively, no one's been taking care of us. We've been doing it. And so we need to speak up and say, this is how it is. Because unfortunately, sometimes, healthcare workers who are working with us are a little bit grandiose about the effect that they're having on our health, when in fact, we're doing a lot of that care ourselves already, which I think is good and right. We should be taking care of grandma, not the government. So, cross-cultural understanding. Here are 11 quick points, really important. Relationships between Aboriginal peoples and their care providers should be based on a foundation of mutual respect. Healthcare professionals should recognize that the current healthcare system presents many gaps and barriers for Aboriginal individuals and communities seeking healthcare, that the system is a problem, that there are systemic problems. It's not necessarily the patient who's the problem, it's the system. That healthcare professionals should work proactively with Aboriginal individuals and communities to address these gaps and barriers. We should be able to talk about it. My client comes in, she's got a problem with crystal meth. I have to say, you know what, this is a problem, I don't know what to do. Let's find out. What services are there on your reserve to help you out? Healthcare professionals should work with Aboriginal individuals and communities to provide culturally appropriate health care. Culturally appropriate health care. Not incompetent health care. Culturally appropriate. And whenever possible, we should be able to receive services in our own languages. I mean, imagine that. Imagine in this kinder universe where we would be able to receive service in our own languages. Just imagine that. Imagine a place where we would go and you would see your cousin behind the desk or in the examining room, and they would, they'd be saying, yeah, let's make you feel better. Healthcare programs and institutions providing service to significant numbers of Aboriginal people should have cultural interpreters, advocates who are hired by that institution, and they should have Aboriginal health advocates on staff. And I know that there are a few probably in this area, but not enough. Number 7, Aboriginal people should have access to informed consent regarding their medical treatments. It's really unfortunate that so many Indigenous clients say, you know what, I had no idea what was going on. Nobody took the time to explain it to me. I didn't have a clue. Or patients or family members of patients saying, I had no idea what they were doing or why they did it, and I'm really suspect about what they did. Number 8, health services for Aboriginal people should recognize the importance of family and community roles and responsibilities when attempting to service Aboriginal individuals, families. Number 9, respect traditional medicines and healers because they're there, because we consult them, because we ask for them. So they shouldn't be excluded. Can you imagine it still happens in some hospitals that they say, you can't have a traditional healer in here. He's got like some grass thing with him. He's got some plants with him. We don't allow plants in here. You can't have, he's not your immediate family member. We're not going to let that traditional healer in. You think a song is going to help you? Forget it. We won't let them in the room. That still happens. Healthcare professionals should take advantage of workshops. And last of all, healthcare professionals should get to know Aboriginal communities and the people in them. And when we work at UBC and we send out our students to communities, we assess part of their success on how well they integrate. If they stand apart from the community, they haven't gotten to know anyone, they haven't done very well at all. So hopefully you'll remember this definition. And in culturally competent care, there are 3 major areas of research, and this is just a reminder to you that cultural competency extends into health disparities, cancer rates, infant mortality rates, breastfeeding rates, pregnancy rates. In access to health care, can we go to the clinic? Do we get good care at Emerge? Can we see a specialist easily? And in the quality of that care, did they, sure you got to see them, but did anything get done? So here's just an example, and I'm almost done. We have this UBC Aboriginal Health Elective whereby we partner with communities to train health science students. So basically, the university sees communities as equal partners in making those students competent. Sure, we can test medical knowledge, but you all can test cultural knowledge. We can test medical competencies, but you can test cultural competencies. And if you're equal partners, then you have equal say. So it's not me saying, oh, you know what, we want you to do a lecture, but you have 2 hours. Every year you have 2 hours to work with our students. The community says, cultural competency in 2 hours? No, we want 24 hours or 150 hours. And we have to say, okay, you're a partner, let's work it out. Relationships and trust are paramount. Just like with those indigenous physicians with each other, lots of knowledge, lots of indigenous people, useless with each other. Couldn't agree on what to have for breakfast, let alone how to care for an entire nation of indigenous people. So it's not just the medical knowledge or the cultural competency, it's the relationship. Aboriginal standards of competency and service. We decide. Are you able? Are you competent? We have a say. We give you a mark as Aboriginal people. Because community members have broad skills that they can teach and vice versa. And as you all know, caregivers who teach are very special. Very, very special. And that's what I would like to encourage in all of you, is the ability to teach. So, at UBC, we give our healthcare workers on reserve. Our frontline workers are given clinical instructorships and associate professorships. And so we should. And so we should. Who else can teach cultural competency but you on the front line? And remember, cultural safety is bidirectional. It goes both ways. So, literally, and I don't mean to sound racist when I say this, but some skinny 21-year-old blonde white chick who comes in, wants to be of help, she can say, I don't know what to do. I've never met an Indian before. I'm scared. And you can say, that's all right. We're going to work on this, and by the end of this, you're going to be competent. And vice versa. The patient could come in and say, I'm scared of white girls. She's too skinny. I don't want to see her. No, I'm kidding. And we can say, look, let's work on that. because, you know, your expectation of never seeing a non-Aboriginal professional again is probably not realistic. Did that sound racist? I hope not. Because it's supposed to be safe in here, right? I can talk about cultural issues in a safe way. I'm going to stop. I have a few more slides, but I've gone on way too long already. And thank you for your attention, and I hope that you got some ideas around some of the practicalities on cultural safety and competency. Thank you.